Hi and welcome back to another video of Medic Notes. This video is on Torsades de points. Polymorphic ventricular tachycardia is a form of ventricular tachycardia in which there are multiple ventricular foci with the resultant QRS complex varying in amplitude, axis, and duration. The most common cause of PVT is myocardial ischemia or infarction. Torsades de points is a specific form of PVT occurring in the context of QT prolongation. It has a characteristic morphology in which the QRS complexes twist around the isoelectric line. The causes of this condition are congenital syndromes, electrolyte abnormalities like hypokalemia, hypomagnesemia and hypocalcemia. Drugs such as quinidine, amiodarone, haloperidol, and many other drugs listed here. Poisons like organophosphate insecticides, and other causes like bradycardia, acute MI, hypothyroid, and CNS diseases. For its clinical features, arrhythmia is usually short in duration and spontaneously reverts to sinus rhythm. May cause presyncope or syncope, and occasionally convert to ventricular fibrillation and cause sudden death. ECG will show rapid, irregular, sharp complexes that continuously change from upright to inverted position. It also shows prolonged QT intervals between spells. For management of torsades de points, any precipitating factor should be identified and removed. Correct hypokalemia and hypomagnesemia and stop culprit medications. Sustained arrhythmia in presence of hemodynamic compromise should be treated with electrical cardioversion as per ventricular tachycardia. In stable patient, cardioversion should be last resort because the rhythm will likely recur or degenerate to VF. Magnesium sulfate is highly effective in treatment and prevention of drug-induced torsades de points. Initial dose of 1 to 2 grams IV bolus over 5 to 10 minutes, followed by infusion of 1 gram per hour for 4 hours. If successful, is currently considered first-line drug therapy. Use cautiously in patients with impaired renal function. Temporary transvenous overdrive pacing, either atrial or ventricular pacing can be used, and this should be attempted if magnesium sulfate is unsuccessful. Other management include IV isoprenaline to shorten QT interval by increasing the heart rate. Patients with congenital QT prolongation are best managed with beta blockers plus/minus class 1B agents like phenytoin and mexiletine. Resistant cases are managed with permanent pacemaker or implantable cardioverter defibrillator and/or left stellate ganglionectomy. That's all for this video. Thank you.